Welcome back, everyone. This is our last lecture that we have for the semester. It's been a long and interesting journey through the exploration of sex offenders as a group and the laws that govern and supervise them. Today we're going to end the semester by examining different treatment methods that are used to rehabilitate offenders. We're going to start by looking at prior methods, and then we're going to segue into more modern treatment strategies. Starting at the beginning, we encounter the era of the sexual psychopath. We have already discussed this topic once before when we examined the beginning of the sex offender registry. Remember that as part of that discussion, we focused on the fear and the panic that is associated with sex offenders and the perceived threat that they pose. Sexual psychopath laws are not as old as we like to believe them to be. Starting in 1937, states began enacting sexual psychopath laws. Remember that California was the first state to implement them. Sex offenders were thought to be different than regular offenders. They are mentally ill, they're depraved individuals, they have difficulty telling right from wrong, or they simply just don't care about the harm that they have caused. Based on these inherent differences, there was a strong desire to make sure they would not be able to harm anyone else. And one of the ways in which states wanted to do that was to get them into psychiatric and medical treatment. From a corrections perspective, it was not until the 1970s and 1980s when we really see a shift away from treatment and we begin relying more on incarceration to deal with the mentally ill. But we used to seek treatment for individuals who we believe committed their crimes due to a mental deficiency or a mental illness. So, sexual psychopath laws allowed for someone who was diagnosed as a sexual psychopath to be confined in a state hospital for an indefinite period of time. We have similar laws today, but we call them civil commitment laws. These laws were based on the belief that committing a sex crime was evidence of a mental disorder. Due to this, the offender required treatment rather than imprisonment. As you can see on this slide, Sheldon Gluck, who was a criminologist who primarily published on juvenile delinquency alongside his wife Eleanor Gluck, commented on the sexual psychopath laws and provided academic support to the idea that sex offenders commit crimes due to psychological issues. The commentary came out in the 1930s, so you can see that the language is a bit outdated in terms of how we would describe mental illness today. So Gluck states that, quote, sometimes he is feeble-minded. Sometimes he suffers from some epileptic condition. Frequently, he is a chronic alcoholic. Often his uninhibited impulses are related to premature senility, end quote. That's a pretty strong, but also much too simple of an explanation. I'm not exactly sure how what epilepsy has to do with committing a sex crime, but that seems to be part of it according to Gluck. Chronic alcoholism seems like it could be a better fit, but we know that most sex offenders do not commit their crime under the influence of licit or illicit substances. Finally, premature senility. Senility implies that the individual is experiencing memory loss or some type of dementia-like symptoms. Again, not really a good fit here because, but you can see from the time period that these might be pretty good explanations for behaviors that community members don't quite understand. There are several issues with sexual psychopath laws, as though you can imagine. Many individuals who were confined under these laws were not even psychopaths, as any other person with a mental illness would be classified as. Many of these sex offenders knew right from wrong and expressed remorse for their actions. Despite these issues, support for these types of laws was high among the public, as they tended to be enacted as a result of a wave of fear that is associated with sex crimes as produced by the media. This is a similar type of community reaction that we are seeing today as associated with the sex offender registry and community notification laws, as we discussed in the prior chapter. If you were institutionalized as part of the sexual psychopath law requirement, most frequently you would receive some sort of treatment while you were in the hospital. In the next few slides, I want to review some of the different treatment options that you may have received. Many of them are severely outdated and highly unethical, but at the time, things were different and medical personnel didn't realize the severity of their actions. The medical community thought that these things were truly helpful and didn't have the medical advancements or research to know the harm that they were causing. Electroshock therapy or treatment is one of those exact types that causes more harm than good, but the medical community believed it to be effective. So this was originally used on the mentally ill individuals before it was applied to criminal offenders. Basically, the patient would be hooked up to some sort of device similar to what you see on the pictures on the screen. An electric shock would be delivered to the brain when the patient would see a stimulus that would be arousing to them. So, for instance, if the patient was sexually attracted to children, then that person might see a picture of a child in a sexual position of some kind. Then the electroshock would be administered, and the idea is that whenever the patient would become sexually aroused, that arousal would disappear because it is now associated with the pain of the electroshock. It basically was aimed at changing the thought patterns of the sex offender through a preliminary version of aversion therapy that we will discuss later on in the lecture. As you can imagine, if the patient was having grand mal seizures or convulsions, then this was harmful to the patient's brain. We normally try to stop seizures from happening, not induce them purposely. So electroshock therapy was not shown to be effective or to work, meaning it did not cure the offender's arousal, and it caused more harm than good. The level of electricity used was far too high and would cause injury to the patient, including memory loss or, in some instances, mental impairment. The second style of treatment or therapy focuses on a style of surgery that removes part of the nerves located in the front of the brain. With a lobotomy, this is an irreversible procedure that was used for many decades before the practice was pretty much eliminated from modern medical practices. But this was again used with mental health patients before it was used on offenders. But really the idea of it was that the doctor would either go through the middle of the forehead or through the orbital socket. The orbital socket was easier to access and therefore more commonly used. The problem with lobotomies, as you can probably assume, is that if you drive a giant stake through a person's head, there is a lot of room for error, and mistakes happen all the time. The doctor may hit the wrong part of the brain or sever the wrong nerves, and the patient might be permanently debilitated, or may even end up in a vegetative state if they didn't outright die. But for many individuals, successful lobotomies never quite cured the issues that medical professionals were trying to fix. For some sex offenders, it made their sexual deviancy worse or made the offenders engage in more drastic behaviors than they did before. Lobotomies essentially cut out the part of our personalities that make us, us. It was a barbaric practice that should never have been performed, but again, this was cutting-edge medical practice at one point in time. Castration is probably the most familiar type of treatment that is out there for you, if you can call what we've been talking about treatment. So castration has been used as a treatment mechanism and as a punishment mechanism. Based on the description of this procedure, this is clearly only something that can be done to a male sex offender. We're going to discuss both physical and chemical castration today. Physical castration is non-reversible and it is a permanent solution. Chemical castration can be reversed, and we'll talk about how in just a second. Basically, castration is the removal of the testes from the man in question, but the penis remains intact. This is a radical procedure and essentially causes the man to stop producing testosterone. In essence, it would eliminate the physical ability to engage in sexual offenses involving the penis. The problem is, many sex crimes do not require penile penetration in order to be completed. Due to the elimination of testosterone production, castration has been found to reduce potency and the libido in male offenders, resulting in low recidivism rates. That's one of the reasons why it is so popular with the general public, who calls for this type of practice to be performed routinely. Sterilization is different than castration and typically involves the removal of both the penis and the testicles. However, sterilization is performed less often because it is regarded as a poor option for reducing sex offending, as it may result in extreme maladjustment. If you think about how big of a mental adjustment it has to be to lose both organs at once, many men are probably ill-equipped to adjust to that type of radical surgery. The downside of castration and sterilization is the medical side effects. Because the man in question is no longer producing testosterone, he will commonly experience hot flashes, hair loss, osteoporosis, softening of the skin, lethargy, and a decrease in muscle mass. So all of these side effects are happening, and they're only going to keep getting worse because the situation is permanent. In addition, due to the permanent nature of castration and sterilization, if there are better treatment options available in the future, then this particular offender would be ineligible to partake in these programs. Furthermore, some states link castration or sterilization to release. This makes the surgery coercive in nature. Either get castrated or stay in prison or the civil commitment program for much longer than you would have to if you would just take part in the castration program. It is a double-edged sword, and some offenders will elect the worst of the two options in order to be released from the institution in question. In the United States, there are no states that allow for mandatory physical castration of sex offenders. However, there are a handful of states that allow for chemical castration of sex offenders because this is a reversible style of treatment. Of those states that allow for chemical castration, California, Florida, and Louisiana allow for repeat sex offenders to elect for surgical castration if they have a child victim and they do not desire to take the medication. In the other states, chemical castration occurs when the male sex offender receives some sort of estrogen-based medication that negates the testosterone that a man produces naturally. For example, Depo-Provera is primarily used as a female birth control. When used in women, there are few side effects, but not many compared to the effects that men exhibit when they are injected with Depo-Provera. This drug is only effective when used correctly. As soon as the offender stops taking the drug, he will start producing testosterone once again. Some sex offenders will turn to the black market for testosterone injections in order to counteract the Depo shots. In clinical trials of using Depo-Provera on 79 sex offenders, the results showed that of those who received the drug, none of the offenders committed another sex crime. This was in comparison to 60% of those who were recommended for the program but who did not receive the drug, and 55.3% of those who were not recommended for the program at all. So those results showed encouraging results for those individuals who received the treatment. And the effects of this drug are reversible, so that was encouraging as well. However, when sex offenders are on Depo for long periods of time, they can develop cancer, diabetes, gallstones, thrombosis, high blood pressure, serious weight gain, and the development of larger breast tissue in males. There are ethical considerations from the state perspective as well. Should the state be administering drugs to offenders that can cause these long-term health problems? Who is going to pay for the treatment of these offenders? Just a question that we should be thinking about long-term. As we move into the next era of events surrounding the treatment of sex offenders, we are moving away from some of the more permanent medical treatments, and we are moving toward more of the psychiatric forms of therapy or treatment. During the 1950s to the 1980s, there was a large push in all areas of criminological treatment to focus on the root cause of the behavior rather than the physical manifestations of that behavior. In other words, what is causing the offender to go out and offend? If we could identify that underlying reason and change the offender's line of thinking, then perhaps the offender would desist in his or her offending patterns. So this means we have to move out of the operating room and into the psychiatrist's office. Offenders need to begin discussing their problems with a treatment provider and find alternative means of expressing their sexual arousal. This was done through 3 primary methods of psychological treatment. The first is psychotherapy, which focuses on the sexual development of the offender. The second is behavioral therapy, which aims to redirect the sexual arousal of the offender. And finally, we have cognitive behavioral therapy, which is the most commonly used and teaches the offender to modify his thought patterns in order to modify his behaviors. Research has suggested that sex offenders are successful in their treatment efforts when they are able to work in group settings. Called therapeutic communities, these are group-based treatment initiatives in which offenders are able to work individually with counselors and then in group-based settings. The goal of therapeutic communities is rehabilitation of those who have had positive community interactions in the past and rehabilitation for those who have not. In order to have a good therapeutic community, then you need to create a non-judgmental atmosphere in which the sex offenders are able to open up and express their thoughts and feelings about what they have done in the past, what they are currently struggling with, and how they think they will be able to do better in the future. This is done in part by socializing the inmates in a small community of other inmates, where inmates who have completed more treatment influence the newer members and help them to develop appropriate social skills. A therapeutic community has a number of standard components. They have primary therapy groups where inmates meet in smaller groups guided by one or more therapists. They have psychoeducational classes where inmates learn coping skills and address issues that will be associated with their individual treatment success. They have community meetings where all members of the community and staff gather to address any problems within the community. In addition, there has to be support from the administrators and the correctional officers. If there is no support, then the offenders will feel as though they are not free to vocalize their struggles for fear of getting in trouble within the institution. Furthermore, you have to have a well-trained and effective staff who know how to provide this type of treatment. The treatment providers cannot be judgmental towards the sex offender. If the offender feels as though the counselor hates him or despises him as an individual for what he has done in the past, then he is not going to open up during treatment. Finally, a good therapeutic community needs to have a few other things. It needs a clear philosophy explaining that there cannot be any more victims. It is okay to struggle with the feelings of arousal, but it is not okay to offend again. The treatment model needs to be grounded in theory and the therapeutic philosophies that have been known to work out in the past. Additionally, the facility and staff are important as well. Without those two key elements, then the treatment will not work well. There are three types of staff that are vital to a successful therapeutic community. First, there is the treatment team. It is important that they have appropriate degrees and training associated with their occupation. They must be able to take criticism and avoid personalizing issues. Next, we have the correctional staff. They must be trained in the treatment of sex offenders. They have the advantage of observing inmates in situations that the treatment staff may not see, which gives them the ability to report valuable information. And finally, there's the supervisory staff. Such staff must be experts in a sex offender treatment. They must consult with the treatment staff regularly to improve their treatment approach and assess their emotional ability to continue work. One of the more recent styles of therapeutic treatment focuses on behavioral treatment. This is a type of non-invasive treatment that tries to alter the physical behaviors of the sex offenders while engaging in treatment methods that do not permanently alter their person like the previous styles of treatment did. While these are more common than other types that we have previously discussed, they are not without their own ethical concerns. If the goal is to try and avert the sex offender's desires, then under the behavioral treatment model, something needs to be done to create that aversion. Once again, there is no strong conclusive evidence that these styles of treatment actually work in comparison to things like cognitive behavioral treatment, but they are still used nonetheless. I want to discuss a few different types of this treatment, but I don't want to spend too much time here since we've already gone through several other forms of physical treatment like lobotomies and castration. But under the behavioral treatment model, a number of forms of aversion therapy can be used to change sexual arousal patterns, including aversion therapies such as shame aversion, ammonia aversion, phoretic or electrical aversion, and olfactory or smell aversion. The idea behind each of these techniques is that the offender will come to associate deviant arousal with something unpleasant, and that will reduce deviant sexual fantasies. Shame aversion is the most ethically questionable and least researched type of behavioral treatment that is used today. With this technique, treatment staff watch an offender in treatment act out deviant behaviors and stare at him, causing him to experience shame. This is a very intimate action that is being witnessed, and the individual is being shamed for it. For example, let's say that during treatment the offender is given a specific type of pornography to watch. The offender becomes aroused and is allowed to masturbate. The treatment specialist will watch him do this. They may laugh, they may point, they may make fun of the offender for being aroused at something that he is not supposed to be aroused by. This can be a very demeaning event for the offender, and through this process it becomes very evident the offender is wrong for his feelings and that he is an outsider who is not normal. Evidence suggests that the offenders going through this treatment experience nightmares and anxiety due to the reactions of the treatment providers. However, only anecdotal evidence indicates that this form of treatment is successful. This means that no formal empirical research has been conducted to analyze the effectiveness of the treatment, and that we only have some individual stories to go off of. Despite the problems, shame aversion is still utilized in approximately 20% of all treatment facilities. Next, we have ammonia and olfactory aversion treatments. These forms of aversion are often grouped, although inhaling ammonia only really triggers the pain system of the body and not the olfactory system. Ammonia is a common household substance and doesn't cause any harm to the individual in the long run when simply used on its own. However, it smells incredibly unpleasant and the smell lingers for quite a while. So basically, in both forms of aversion therapy, it requires the offender to inhale either ammonia or something else in response to deviant fantasies or exposure to simulations of their deviant interest. An offender in treatment will watch films or will see pictures with their deviant interest featured, and they will then inhale the unpleasant substance. The idea is similar to that of Pavlov's dog. When you reward someone with something pleasant, then they know what to do when the bell rings. If there is a negative experience associated with the ringing of the bell, then they are less likely to engage in that behavior because they don't want to experience the negative effect again. As treatment progresses, the offender's erectile response to the deviant sexual stimuli can be tracked over time to determine if the treatment is causing a reduction in arousal. If all goes well, then the offender will associate the arousal with the negative substance and will no longer feel aroused when seeing the specific material. Offenders are also encouraged to self-administer the unpleasant substance should the deviant fantasies occur. A case study indicated that this method reduced the amount of time spent in masturbation to deviant fantasies. But again, no real empirical research has been conducted on this type of aversion therapy. Finally, there is sporadic aversion treatment, and this one has proven to be the most effective at reducing deviant sexual arousal if it is applied when evidence indicates that such arousal is occurring. So the premise of this style of treatment is that a therapist or a clinician will monitor the offender's erectile response to a sexual stimuli. This will be dependent on the offender and his specific sexual preferences. If the offender becomes aroused after viewing the stimuli, then the clinician will administer an electric shock to the offender. This type of electric shock is much lower in frequency than the previous style of electroshock therapy that we discussed earlier in the lecture. Instead, this one is only applied to the fingers of the offender and is relatively harmless, just enough to get the offender's attention and make him remember that response. When an erection is present in response to an appropriate sexual stimuli, no shock is applied. Researchers have found that those subjected to sporadic aversion reduced erectile response to deviant sexual stimuli, but critics suggest that this could possibly be attributed to offenders learning to inhibit their erections. The final thing I want to discuss in lecture today is the idea of cognitive behavioral therapy. This is one of the most well-researched and studied types of therapies that are out there today. It started as a way of helping substance abuse patients get over the addiction of whatever they were using because it focuses on both the mental and physical aspects of addiction while accounting for relapse management. Many offenders of any variety are exposed to treatment while they are either incarcerated or once they are released but are still on state supervision. Treatment is important because for many individuals, they will be living on their own and they will need to manage their desires accordingly so they don't end up back in prison because they couldn't curb their cravings. Cognitive behavioral therapy is built on select core principles that will help alter the offender's behavior by first altering the offender's thoughts. While I'm not going to spend a lot of time explaining each of the 13 principles, you can find them in your text. Very briefly, they include 1. Functional analysis and contingency management, 2. Skills training, 3. Exposure therapy, 4. Relaxation, 5. Cognitive restructuring, 6. Problem solving, 7. Self-regulation, 8. Behavioral activation, 9. Social skills, 10. Emotional regulation, 11. Communication, 12. Positive psychology, and finally, number 13 is acceptance. For many offenders, they don't necessarily believe that their actions are wrong because they do not feel as though their sexual attraction is wrong. If the thoughts and desires feel natural or right, then it is difficult to convince the offender that their actions are wrong. These false thoughts or cognitive distortions are the first things that need to be overcome. For example, if the offender believes that children are sexual beings and are interested in sex or are sexually attracted to the offender, then the offender must be convinced that this is simply not true, that young children are not cognizant of sexual desires yet and are not sexually attracted to the offender. In other instances, the offender may not feel as though their sexual offending patterns are harmful to the victim. Once again, the offender must be shown that their actions are really harmful and are causing trauma to their victims. It may take the victim years and years to cope with the harm that you have caused. It's a long process that the offender must go through to completely change his or her thought process, and even then they might not be successful. They may struggle for years and years to come. Cognitive behavioral therapy often utilizes individual and group level treatment settings and treatment mechanisms such as role-playing to help get through to the offender. Role-playing can help the offender work on some of the interpersonal skill deficits that are associated with sex offending. Furthermore, this is an effective tool in addressing the offender's possible lack of empathy that is also associated with sex offending and can be treated by examining victims' reactions to help the offenders understand the victim's perspectives. While I did not go over all of the possible treatments available to sex offenders during this lecture, I wanted to cover some of the most used and the most controversial ones that are used or have been used in the past with this offender group. For a long while, treatment was not commonly used with any offender groups because the criminal justice system viewed offenders as being incapable of change. This mantra of nothing worked was a common one after researcher Robert Martinson wrote an article in 1974 that addressed the question, what works, in terms of offender rehabilitation. His response was that nothing works. As you can imagine, state and federal legislators jumped on this article and used it as suggested proof that offenders were unable to be rehabilitated. Furthermore, Martinson was an academic researcher, a well-respected source for policymakers to cite. So for many years, state and federal governments wiped out the majority of treatment funding for sex offenders and all other types of offenders because you had this one researcher telling the world that you might as well stop all rehabilitation efforts because nothing works. On your class website, I have uploaded a rebuttal article from Francis Cullen and Paul Ginroux that discusses how you need to update your treatment mechanisms and strategies and create treatment programs that are effective in the 21st century. Sure, lobotomies and electroshock therapy aren't as effective as you want them to be, but what if we looked at something different and focused on those parts that do work? This lecture is our last one for the semester, and I'm sure you're all ready for a break. I certainly appreciate your time and attention in focusing on this topic with me this term. I know that examining sex offenders at this in-depth of a level can be exhausting at times and can be personally trying to get through. But it is an important discussion to have in terms of the legal and personal ramifications of the actions that these offenders engage in. Thanks again, everyone, and I hope you enjoy your upcoming break. Bye!